Good day, fellow learners. This is your mentor, Dr. Ray Gapuz, your fact check buddy, joining you for another teaching and learning session that's special. Why special? Because a former viewer and student, eventually became a student, and an NCLEX RN passer has requested for this topic. Okay, so let me read through her email. This is coming from Leron Mills. Hello, Mary Jane, and she channeled it through our office coordinator. I know it's been very long time. Definitely miss talking to you guys. I sent a message to Mentor Ray weeks ago, wanted to know if he can make a video about CVA or stroke and the different types, hemorrhagic and ischemic. Hope all is well. I still look at the videos on YouTube since you guys helped me pass my exam. So thank you very much, Leronda. I know you're doing this for your friends. And so here is your requested topic. I'm so sorry I wasn't able to see your mail. Maybe it went to the spam. And so this is very clever on your end to get in touch with Mary Jane, our ever reliable and courteous and hardworking staff at the Ray A. Gapuz System Office here at the United Nations Avenue in Manila, Philippines. So today's focus would be about, as Leronda actually requested, CVA or stroke. And I added one important thing that you have to know in relation to this concept, and that is risk for unilateral neglect. So let's begin with a sample question. And it goes this way. Which of the following complications are related to the ECG tracing below? Select all that apply. And then you have several options and, of course, an exhibit. So this question is difficult. Why? It's actually asking you to do several things. And what are these? First, you will have to analyze and then interpret and identify the condition of the patient as it is reflected here on the EKG tracing. And then after that, you should be able to recall the complications of that condition. So which means everything starts with interpreting the EKG pattern. Now, if you have that difficulty, pause the video now. We have two videos on EKG interpretation, one that highlights just the tips, and the second one is a comprehensive discussion that's more than an hour, but I actually would have to tell you it's one of the most watched and most loved videos that we have to date. Why? Because it simplifies the EKG interpretation for nurse test takers of the NCLEX RN by identifying just three main steps. So for you to learn that, you could actually go to our YouTube channel and then look for the EKG simplified interpretation video. Before we answer this question, just like in the other videos that I came up with, I would like to ask you to join me in this mission, our team, us, of course. Our goal is to provide free NCLEX RN application and review to 100 nurses. We were able to do that last year. We would want to duplicate them again this year. And to help us achieve this, just watch and finish the ads in our videos. Thank you. So let's begin with an inspiration from the mail. Now, these inspirational messages, letters, and emails of appreciation really perks me up to do more for everyone. And I really love reading the very, very appreciative messages of everyone who has visited our YouTube channel, went through our videos, and passed the test. Really, nothing beats something that is done from deep within the heart. And here at Ray A. Gapuz System, we do everything from the heart. So let's begin. So I'd like to congratulate a US RN from Manila who passed the NCLEX RN by watching our videos at Gapuz Mentors YouTube channel. And her name is Criselda Bayo Garcia. Thank you so much, Sir Gapuz. You guys really helped me achieve my American dream to become a nurse. I hope you still have more people that you can help. She said that in Tagalog, and she says, marami pa po kayong matulungan. And then, of course, Tharlene Sabiniano. Hi, Sir Ray. I just want to say again and again and again how thankful I am to you and your marvelous team. Thank you very much. You know, Ray A. Gapuz System is made up of a team of dynamic, mission-driven individuals who share the same passion as I do, and that is empowering the nurse to turn their great American dreams to reality using the functional concepts method, which is a registered trademark of the Ray A. Gapuz system. And that method is unique to our team. Okay, I recently passed the NCLEX RN exam last March 8th, very, very recent, after 4 to 5 months of intensive review under your care. We did that, especially for those who graduated so long ago. So we'd like to give them an opportunity to breeze through the concepts and then let them master. Remember, the key is mastery. That's the key to passing the NCLEX RN. Your functional concepts helps me to stay focused and understand every important details. I hope you will still continue your advocacy on helping nurses like me with big American dream. God bless you, sir. To you and your team, Tharlene Sabiniano, RN, SEHRN, USRN. Congratulations, Tharlene. My hat's off to you. And of course, Tharlene recently joined our team of mentors. So here she is. Finally, Tharlene May Sabiniano of Southeast Asian College, USRN, and she passed the NCLEX from the New Mexico Board of Nursing last March 8, 2022. And this is how excited she was. It was 10:30 in the evening when she sent me her results. And let me read through the message. And she says, "Hi, sir. Good evening, po." And then sent a screenshot of her NCLEX that says at the bottom, pass. And then she followed that up with a message of thanks saying, "Maraming salamat, sir." In English, thank you very, very much. Okay, sobrang salamat po. I cannot find the right words to thank you and your team for your support and wonderful lecture program. Well, she went through 4 different phases of the review programs that I created for their group of learners. And this is actually a customized program depending on what they need for the test. Okay, so let's move on. Reminder, a copy of the slides in this presentation will be sent to your email once a request is made through our email. So just send me an email if you want a copy, a PDF file of this presentation, gapuz.mentors@gmail.com. Now, let's begin with our first functional concept. Cerebrovascular accident, or CVA, or stroke, is caused by the interruption of blood flow to the cells in the brain. And that interruption could be brought about by 2 main pathological conditions. There could be a blockage of the flow of blood caused by several factors, which we're going to discuss in a while, or there could be diminished blood flow that could have been related to bleeding. Okay, so there are 3 general types of stroke. Okay, and it includes the following. First, ischemic. This is what I'm talking about. It's due to the blockage of a blood vessel. It's the most common one. Actually, 87% of stroke cases could be attributed to ischemic stroke, and it could be embolic or thrombotic. What's the difference? Embolic stroke or cerebral embolism is another term, could be due to the presence of a clot that has formed in another organ in the body and that has traveled to one of the small blood vessels in the brain. Like, for example, when your patient has atrial fibrillation and the atrial rate of contraction would go like 250 to 400 beats per minute. So instead of the heart contracting like this, then it becomes so fast, okay? So in essence, it's just quivering. And because of this, blood stasis occurs. So it means the heart can no longer pump the blood out of its different chambers, and so blood clots form. And when one of those clots would lodge into the small arteries in the brain, then that is called cerebral embolism. That's why if you'll be asked on the test, who is most at risk to stroke, it's going to be a patient with atrial fibrillation. And if you are asked in the test, why does a patient with atrial fibrillation need an MRI? It's because most clots that may potentially cause stroke are cardiac in origin, which simply means the clot originated from the heart and then it went into the brain. Next, thrombotic stroke could be related to a clot that has formed in the brain. So embolism from another organ to the brain. In thrombotic stroke, it has formed in the brain. And then hemorrhagic stroke is related to the rupture of a blood vessel that could be potentially caused by a rupture of the intracerebral artery, or subarachnoid hemorrhage could occur. Now, if we talk about subarachnoid hemorrhage, it's bleeding that occurs in the space between the brain and the tissue coverings of the brain. So remember that from the outer to the innermost, we have the dura mater. The arachnoid mater is a web-like structure, okay? And of course, the innermost layer is going to be the pia mater. So the dura mater, the arachnoid mater, and then the pia mater. So when bleeding occurs at the subarachnoid area, meaning underneath the arachnoid space, so that could potentially lead to stroke. Now, if you would take a look at the difference between ischemic and hemorrhagic stroke, in ischemic stroke, the problem is absence of blood supply, which essentially deprives the brain of oxygen. In hemorrhagic stroke, the problem is bleeding, okay? That could eventually also lead to diminished oxygen level in the brain. But definitely, the goal of care would be different. In ischemic, you will have to prevent blood clotting. In hemorrhagic stroke, you will have to prevent bleeding. So in essence, you may want the blood to at least clot to prevent the effects of hemorrhage or bleeding in the brain. And then we have a condition called the mini stroke. It's called TIA, transient ischemic attack. It's actually brief. It disappears in 24 hours even without treatment, and it doesn't cause permanent brain damage. However, the presence of transient ischemic attacks, which could be sometimes described as if the patient is having daydreaming state, and they may become non-responsive for a couple of seconds, and then eventually the signs and symptoms disappear. It doesn't last that long. However, transient ischemic attack could be predictive of an eventual stroke that could be associated with either ischemic or hemorrhagic stroke. So which means history of transient ischemic attacks could be found in patients who eventually develop full-blown stroke. Now, what are the common risk factors of stroke? You have the code FA-BOSS, so family history, advancing age, especially when you're growing a little older, when the blood vessels becomes a little more non-elastic. It's common among African Americans or the Black populations, and obesity, which means patients with a BMI of 30 and above. The normal BMI is 18.5 to 24.9. The moment you reach 25 to 29.9, that means you're overweight. And when your BMI is at 30 and above, then that means you are obese. Okay. And then, of course, stress, which activates the autonomic nervous system, and smoking, which could potentially cause vasoconstriction, and that could lead to a sudden increase in blood pressure. That could potentially lead to stroke. Okay, now, what are the common symptoms of stroke? So we have here the code stroke. One is sudden speaking difficulty. The patient will suddenly have slurred speech. And then there's total loss of balance or coordination that will make it difficult for the patient to walk. And then responsiveness decreases. So that means to say the sensation and their ability to respond to stimulation, like visual stimulation or sensory stimulation of the ears, are diminished. And then visual problems, blurring of vision, kinetic abnormalities, they are unable to move their muscles. So there's going to be weakness, and then, or paralysis, and then excessive sudden headache, which really would tell us that the blood pressure could be increasing. Now, the signs and symptoms of stroke could actually be related to the parts of the brain that are affected. So if the frontal lobe is the one that's affected, so you have problems in speech because the Broca's motor speech area is responsible for the ability of the patient to find the right words to say, and that's on the left frontal lobe area. So if that is affected, the patient will have expressive aphasia. Motor function abnormalities, including difficulty in remembering things or memory impairment. Remember, memory is a function of both the frontal and then the temporal lobe. Then control of morals, emotion, judgment, personality, and concentration, problem solving, impulse control, reasoning, and planning. So remember the 3 P's for a frontal lobe. It's personality, problem solving, and planning. And on the parietal lobe area, okay, remember SPOR. So sensation, pain interpretation, orientation, reading, and arithmetic. And then the temporal lobes, you have the auditory center, then memory, perception, and recognition, Wernicke's language area. So if the Wernicke's language area is affected, the patient will have receptive aphasia or difficulty in understanding, okay, spoken words. So which simply means the patient, for the patient to be able to communicate in an understandable manner with the nurse, it's very important that they have to use communication board or picture board and to provide them with adequate time to respond. So if the patient has difficulty communicating with the nurse, it's very important for the nurse to make the necessary adjustments. And then if there's a tumor on the temporal area and hearing could be impaired, if the patient doesn't understand this, it could be reflective in their asking the nurse about using their headset or headphones post-operatively, and that indicates knowledge deficit on the part of the patient. So it's very important for the patient to know that if they have a tumor affecting the temporal lobes, they could have hearing impairment after. Okay, so next important thing would be the occipital lobe, which is responsible for visual processing. Now, if you may want NCLEX related or NCLEX style questions related to this concept, there's a separate video that I created. It's entitled The Lobes of the Brain. You could actually search it through our YouTube channel, okay? So that's additional thing for you to do, but if you may want to dig deep into this, because in that specific video, I focused more on the NCLEX style related questions related to this concept. Okay, now, what is unilateral neglect? So unilateral neglect results from injury to the cerebral cortex. So in unilateral neglect, the patient fails to dress, shave, or groom the affected side, which means the side opposite the brain lesion. So we have here an illustration. For example, if we have a lesion or stroke on the right side of the brain, okay? So what happens is that the right face will be affected, and look at this area at the junction of the medulla and the spinal cord. That's where spinal decussation occurs. Spinal decussation refers to the crisscrossing of the motor fibers into the other side. So which means right brain stroke would affect the right side of the face and the left side of the body. So in order to simplify this, it's like when you have a stroke here, if this is labeled, for example, as the right side, the affected body part would be on the left side, but the affected facial part would be on the same side, the right part of the face. So stroke at the right side of the brain will affect the right side of the face, the left side of each eye, leading to homonymous hemianopsia, the left arm, and the left leg. So we call this left neglect. So since the patient had a right side stroke, they would be unable to groom as well as to be able to take care of the left side of the body. So therefore, if the patient has a right brain stroke, you will need to put the call bell on the right side because the left arm may not be able to press it. So it's the right arm that they can use to call on the nurse whenever they need assistance. Okay? So if you will be asked what is a nursing diagnosis that is appropriate rather for a patient with a right side stroke, then you could answer risk for left unilateral neglect. And if it's the other side, if it is left brain stroke, risk for right unilateral neglect, or wrist for unilateral neglect, left side, or wrist for unilateral neglect, right side, depending on which side is affected. Okay, now stroke on the right side of the brain that affects the visual cortex can blind the left side of each eye. So right part of the brain can blind the left side of each eye. So which means, how would you know that? When they are eating and they're just consuming the food on the right side of the plate, and they're not touching the food on the left side of the plate. So which means the patient is having homonymous hemianopsia. Now, a safety implication of that is that when they're crossing the streets, they may not be able to fully see whether they're approaching vehicles. So it's important for the patient to be informed that they have to look from both sides, okay? And they have to look from side to side before crossing the streets. Now, to recognize the symptoms of stroke, remember to always move fast. What does that mean? FAST is an acronym for four areas that you need to be familiar with. Look at the face. Is there a sudden drop on one side of the face, or is there an uneven smile? And ask the patient to raise the arms. If one would actually drift downward, so that could mean that the patient could be having stroke. And then the speech, is it slurred? If the patient's having all of a sudden difficulty speaking, that could be stroke. Now, timing is very crucial because studies have suggested that within 3 to 4 hours, if the patient comes into the hospital and is treated right away, they are more likely to suffer from less complications, and they would be able to move towards rehabilitation faster than the rest, okay? So this is actually difficult for patients to do, especially if they are all alone, and especially that stroke is one of the most common cardiovascular diseases in the United States. In fact, okay, in the US, somebody would usually have a stroke every 40 seconds and every 4 minutes. Statistics have shown that someone dies of stroke, okay? So that's how common it is. So it's very, very important that we need to act fast when we suspect that the patient is having a stroke. Now, once the patient is brought to the hospital, the patient would be undergoing tests to diagnose a stroke, and that would include MRI or CT scan. It's going to be visualization of the brain. Of course, the MRI provides a more detailed visualization of the brain, and it helps facilitate the identification of which part of the brain is usually affected by the stroke. And then, of course, EKG is usually done because, as I told you a while back, most clots that cause stroke are cardiac in origin. That's the reason why sometimes patients with diagnosed with atrial fibrillation are advised to undergo MRI. So carotid ultrasound is usually done in order to detect abnormal blood flow, because the carotid arteries are considered as the main blood vessels that supply the brain with blood. So what we would like to find out in carotid ultrasound is if there is an abnormality in the blood flow. Okay, sometimes doctors would be assessing for the presence of a bruit on the neck. Now, this indicates abnormal blood flow. Cerebral angiogram is usually done in order to identify which blood vessels in the brain are usually affected. So, of course, this would require the use of a contrast medium followed by X-ray visualization of the brain, and definitely blood tests, specifically for cholesterol levels, because an elevated cholesterol would be associated with incidence of stroke. So some of the blood tests could also include determination of blood sugar, as well as the determination of the presence of infection, which could potentially be related to the patient's condition. Okay, so the goal of stroke treatment is, one, if it is caused by ischemia, to restore blood flow to the brain, and if it is caused by hemorrhage, to control bleeding in the brain. So what is important for us to remember is that the priority goal of care depends on the type of stroke. Okay, it's not just the goal that depends on the type of stroke. Also, the treatment would usually be dependent on the type of stroke. Okay, so treatment of stroke depends on the type of stroke. So the first one here is injection of tissue plasminogen activator, or TPA, in a blood vessel is considered the gold standard in the treatment of ischemic stroke. Remember, ischemic stroke could be related to embolism or thrombosis or a blood clot, and must be given, your TPA must be given in 3 to 4 hours after a stroke. Now, there's an issue here. What if the patient is a female and the patient is menstruating? Is it safe to administer TPA as it is perceived to potentially be making the menstrual flow a little more severe? Now, according to literatures, menstruation is a theoretical contraindication of the administration of thrombolytics like TPA. However, if your patient is having ischemic stroke, the goal is to prevent formation of more clots and to prevent the enlargement of the existing clots and potentially to reverse the clot formation. Therefore, recent evidence suggests that intravenous administration of TPA is safe in menstruating women. Therefore, I can say menstruation is not a contraindication for the administration of intravenous TPA. Now, if it could potentially worsen bleeding, then the patient would be a candidate for blood transfusion. Okay, let's move on. Tissue plasminogen activator works by dissolving the clots. So this is best given within 3 to 4 hours after the diagnosis of ischemic stroke. The surgical removal of a clot, mechanical thrombectomy, is most successful if performed within 6 to 24 hours after a stroke begins. Now, however, if the stroke is hemorrhagic in nature, we'll have to tell the patient to avoid anticoagulants. So if the patient is suspected of having hemorrhagic stroke and the patient's taking ginkgo biloba, that's a red flag. Or the patient's taking aspirin because of arthritis, that's a red flag. Or if the patient's taking other herbal remedies like chamomile, ginger, okay, garlic, all of this, chamomile, ginger, garlic, ginkgo, and ginseng can potentially worsen bleeding. Okay, so it's very, very important that collecting data related to these herbal remedies and other maintenance medications that could potentially worsen the patient's condition should be done by the healthcare provider. Okay, so let's move on. In hemorrhagic stroke, surgery can repair a weak blood vessel, remove blood from the brain, and reduce pressure in the brain. So common stroke medications include the following. So thrombolytics, that includes your tissue plasminogen activator. This is usually given if your patient is suffering from a stroke related to a clot, an emboli, or a thrombose. Anticoagulants like warfarin, your antiplatelet like clopidogrel or aspirins also given to the patient. Patients with transient ischemic attacks are usually also given aspirin, okay, to prevent the formation of clots. And then your statins to prevent the accumulation of cholesterol. These are best given at dinner time. You have simvastatin, atorvastatin, rosuvastatin. Just make sure that to remind the patient that this medication could cause hepatotoxicity. Therefore, if the patient is having jaundice or the eyes become yellowish, but let's actually remind our brothers and sisters of African American descent, it's usually normal for them to have yellowish sclera. But if they're taking simvastatin, it's very important that the nurse should reinforce in which body part should they be assessing jaundice, because jaundice could potentially indicate hepatotoxicity. And take note that your statins are best taken with dinner. So That is because most of the cholesterol deposition occurs at nighttime before 10 p.m. and that's when the medication should be given, so it helps prevent the accumulation of cholesterol. And then antihypertensives like Unilateral, that is to ensure that the blood pressure of the patient remains normal. Okay. Now, a post-stroke patient must be referred to a speech therapist, potentially because they will have speech or speaking problems, and they would have difficulty swallowing. So for those concerns, you need to have a speech language pathologist or a speech language therapist. Cognitive therapist is actually needed to reinforce learning skills that were lost by the patient during the stroke. And this could be done by the occupational therapist. Now, the occupational therapist is primarily concerned with fine motor movement, like the things that we need to master to perform activities of daily living properly. Like, for example, in patients with rheumatoid arthritis who have babies, they need to be referred to an occupational therapist because in rheumatoid arthritis, eventually they have swan neck deformity and ulnar drift. So in essence, since patients with stroke eventually develop difficulty with fine motor skills like opening a bottle, okay, opening the doorknob. So they need to be referred to an occupational therapist. Now for gross motor skills like walking or body movement or turning from side to side, that has to be facilitated by a physical therapist. So the difference, the occupational therapist concerned for fine motor skills or activities of daily living, physical therapist, gross motor skills or body movement. And if the patient eventually develops signs and symptoms of dementia because of vascular affectation, or we term this vascular dementia, so they will need a psychiatrist, and definitely they will need a neurologist to address the neurological deficits that develop. Okay, so 80% of stroke cases can be prevented by number one, quitting smoking, and then number two, maintain a healthy diet, okay, and three, exercising regularly. So stroke complications may affect various organs like the heart, the lungs, the kidneys, the muscles, blood vessels, urinary system, and the reproductive system. Now, I'd like to highlight these functional concepts. The risk of kidney failure is greater for people with chronic kidney disease who also have atrial fibrillation. So can we therefore say that patients with atrial fibrillation could be at risk for kidney failure? Yes. Atrial fibrillation increases one's risk for vascular dementia. So what can we see in the history of a patient who was diagnosed with vascular dementia? It could be a history of atrial fibrillation. And then atrial fibrillation can cause pulmonary embolism. Now remember that pulmonary embolism is different from pulmonary fibrosis. When you say pulmonary embolism, you have a clot in one of the blood vessels, in the pulmonary blood vessels, whereas in pulmonary fibrosis, there's usually scarring of lung tissues that could be secondary to infectious conditions. Like, for example, those who've had COVID, like myself, I did have a critical COVID pneumonia. So those who've had medications associated with some conditions, treatment of for some conditions, could develop pulmonary fibrosis. And of course, those who have been exposed to pollutants could potentially develop your pulmonary fibrosis. Okay, so that's how we differentiate pulmonary embolism from pulmonary fibrosis. Okay, with atrial fibrillation, the heart is unable to pump blood properly, leading to blood stasis that causes clots to form. That's what I'm saying. In atrial fibrillation, the heart rate, okay, would usually become faster because the atrial rate of contraction would be from 250 to 400 beats per minute. So essentially, just causing the heart to quiver, that leads to blood stasis in which clots form. And then when those clots would lodge into the small blood vessels in the brain, then you have stroke, ischemic in origin, thrombotic or embolic. So When a patient would usually have atrial fibrillation, blood thinners or anticoagulants are usually given to patients like aspirin, heparin, okay, warfarin, okay, to prevent stroke. Now, let's try answering the sample question that we had a while back. So which of the following complications are related to the ECG tracing below? Select all that apply. So we have cerebral embolism, yes. Pulmonary fibrosis, no. It has to be pulmonary embolism. We differentiated that. And then dementia, yes. Remember, vascular dementia could result from stroke, and then kidney failure. Now, how did we arrive at that answer? First, as I've been telling you a while back, you have to interpret the EKG tracing. Notice that the distance from one QRS to another are not equal. So you have here an irregular QRS. And notice that you have several P waves before the QRS complex. Normally, you have a 1:1 ratio, one P wave to one QRS complex. In this case, you have several P waves that are small, and these are now called fibrillatory P waves, okay? And when you have these fibrillatory P waves plus irregular QRS, these are the general characteristics of atrial fibrillation. And a patient with atrial fibrillation could be at risk for pulmonary embolism, cerebral embolism, dementia, and kidney failure. Okay, so I hope I was able to give you the essential concepts that you need, Lironda, for your friends. And for those who may want to request for other topics for me to cover, let's learn together. Send in your request to my email, mentor.raygapuz@gmail.com. So this has been your mentor, your fact check buddy, Ray Gapuz, saying a functional concept a day keeps your NCLEX RN fears away. So if you love this video, please don't forget to subscribe, share, and hit the like and bell notification buttons so that you'll get notified whenever we upload a new video, and we do that every week. So those of you who would want to have a guide on which set of videos do they need to watch for their specific test for a specific state, please don't hesitate to send me an email, and I'm going to send you that study guide for free. So once again, this is your fact check buddy, mentor Ray Gapuz, saying thank you to my friends in India. Namaste.